This is Neil Dilworth. I'm going to be presenting on behalf of Mr. Thomas O'Neill, who is kind enough to take time out of his busy schedule as a plastic surgeon in Scotland to give us a review lecture on head and facial injuries. Tom O'Neill has no conflicts of interest to declare and got the images from his lecture from Google. He's broken down the talk into a number of different categories. It starts off with fractures of the face, followed by dental injuries, perioral lacerations, ocular injuries, and then trauma to the ear. From there, he goes inside the cranium and covers central nervous system, acquired and congenital injuries, as well as some miscellaneous conditions. So we're going to get right started, starting with fractures. So the first one are orbital fractures. These are almost always due to a direct blow to the orbit. Some of these can be fairly superficial, obvious. If it affects the orbital floor, sometimes it would be less obvious on appearance. The differential diagnosis, obviously, having a traumatic force to that region, is a nasal fracture. Obviously, lateral to the orbit, you have the zygomatic arch. Inferior, you have the maxillary bones. And then in more severe injuries, a Lafort fracture. On examination, it's very, very, very important that you take a look at the visual acuity. Don't allow essentially the acute swelling that can occur, which leads to the eye being shut to prevent you from essentially examining both the visual acuity as well as the pupils. They can often give you a clue as to the underlying injury. You want to look for both binocular vertical and horizontal diplopia on your oculomotor examination, as well as taking a look at the eyes for any evidence of anophthalmos or hypoglobus. In children, you can look for a white eye syndrome and a ocular cardiac reflex. Obviously, you want to be documenting and keeping in mind if there's any evidence of entrapment, specifically on upward gaze. Just the more superficial muscles more likely to get caught. The swelling that occurs with these injuries can make some of these signs easier to elicit immediately after the injury before the swelling begins to complicate the interpretation of clinical signs. So a couple of things when you take a look at the image to the right. This is a CT scan, and that's the gold standard for taking a look at the majority of facial fractures. One of the things that happens with orbital floor fracture is that you essentially get resultant hematoma and swelling as a result of the fracture that affects the infraorbital space. That can essentially push on the optic nerve, that can affect the eye and the eye movements, but also, depending on how bad the fracture is, the actual mechanical features of the fracture can lead to entrapment of the muscles. That fracture can also lead to, and this is what you're seeing in the image there, bleeding that goes into the sinus. One of the things in terms of from a management perspective that we want to try to avoid is increasing any kind of intraocular and extraocular pressure, such as blowing the nose. So that's a very important advice that you want to essentially have the patient player know on pitch. And then from a management perspective, obviously icing, and then having set up for a ophthalmology appointment by getting to a emergency department for further assessments. Very important. You may want to consider prophylactic antibiotics as well in these situations. Zygomatic arch. This is essentially the bone that essentially overlies the upper part of your cheek. Underlying the muscle is underlying the bone. The zygomatic arch bone is the masseter muscle. Once again, this is due to direct facial trauma. Differential diagnosis here, similar to orbital fracture, is the surrounding areas. So you can get an orbital fracture that can appear similar to a zygomatic arch, and sometimes they can happen in conjunction with each other. Same with the maxillary fracture. You have a globe rupture, may be somewhat similar, retinal detachment, and Lafort's fracture. On examination, you want to look for that swelling. They're going to have asymmetry when you look at their face, specifically at the zygomatic arch. So it's going to protrude on the affected side. You want to look for an ophthalmos. You want to take a look to see if there's any kind of malocclusion of upper teeth, which might give you a hint, or trismus, that there may be an associated mandibular or alveolar injury. In terms of investigations, typically, once again, from an emergency perspective, we're going to want to do a CT scan. It is possible to see isolated arch fractures on plain film, but you want to be able to assess the surrounding structures as well, so it's just best off to go for a CT. In terms of management, the arch is largely cosmetic, unless it's a severe comminuted fracture. Something along the lines of what you're seeing there on your right. On the right, once again, you see an axial view of a CT scan, and you can make out that the zygomatic arch is comminuted in several places. That may, in fact, lead to entrapment of the master muscle and cause trismus. And in situations where that's occurring, they may require a procedure called a Geel lift. Between 10 days and 2 weeks after injury. A ZMC, or zygomatic maxillary complex fracture, that's essentially a more severe fracture. Again, that would need open reduction and internal fixation. Nasal bone, this is quite common. It's a clinical diagnosis for the most part, especially if you see the nasal bone itself is deviated following a direct blow. Once again, this is direct trauma. It can happen in all sorts of different sporting activities. The differential diagnosis is a maxillary fracture, orbital fracture, floor fracture. The other one is an underlying ethmoid fracture, and perhaps a sphenoid fracture as well. Generally speaking, no imaging is required. However, with severe injuries, you may want to essentially consider doing a CT scan to look for underlying facial fractures. The concern, once again, on examination is deviated septum, and then looking for a septal hematoma as well, which can lead to, if it's missed, can lead to necrosis of the septum. Best time to reduce fracture is either immediately or after the swelling goes down in 10 to 14 days. Once again, you want to look for a septal injury on the examination. Elective surgical intervention can occur after a season or after their careers ended at any point. For the reductions, some players will let you do it right away as necessary. You can do essentially a nasal block with local anesthetic, essentially putting the local anesthetic on either side of the nasal bridge, which provides fairly decent anesthesia for reduction. Mandible. So mandible fractures or broken jaws. 60% of cases there is a second fracture. So once you see one, make sure you keep an eye out for another one on the imaging. Once again, it's due to direct trauma. Rarely it would be due to essentially a idiopathic process such as osteonecrosis or a tumor. The differential diagnosis is obviously mid-face fracture and fracture subluxar cervical teeth. On examination, this is one where you want to essentially try and take a look in the mouth as best as possible for associated injuries such as intraoral lacerations, any kind of occlusal step, malocclusion, gap indentition, a sublingual hematoma, which may indicate a more significant oral floor injury, and then obviously the associated dental injuries as well. In terms of investigations, CT is probably the best here as well. You can, if you have an X-ray panorama for lesser injuries, that can usually identify the fracture. CT will be able to determine whether there's any kind of associated injuries. In terms of management, you want to assess the airway. Obviously, You may need to stabilize an unstable mantle fracture with bridle wires in some rare circumstances to protect the patient. And you also want to assess for vascular injury given the proximity to the underlying neck vasculature. And then from a perspective of treatment, some of these don't need any kind of surgical intervention and may just heal as is. But others may need essentially a maxillomandibular fixation, open versus closed reduction, and direct versus indirect fixation depending on the presentation and the extent of the injury. Maxillary fractures. So the maxillary bone was present on both sides, essentially underlying the cheek, just anterior to the zygomatic bone. Once again, these are fractures that are the result of direct trauma to the area. The maxilla bone also forms the inferior part of the inferior and the lateral border of the orbit. So the differential includes essentially an orbital fracture, a zygomatic fracture, a zygomatic maxillary complex fracture, and LaFour fracture, which is fracture of the face. On examination, you want to take a look at, once again, take a look in the mouth, make sure there's no lacerations, step-offs, or gaps in the palate. Generally speaking, you'll see a large contusion over the cheekbone, as well as asymmetry in the face on the affected side of the injury. And once again, taking a look at the eye for any kind of evidence of ophthalmos. And then looking inside the mouth once again, make sure that there's no issues with essentially their bite, making sure there's no malocclusion. Investigations, once again, CT scan is the gold standard for facial fracture injuries. Management, most often it's just conservative management for an isolated maxillary fracture. If it's part of a more significant fracture such as a ZMC, then a zygomatic maxillary complex, then it may require focal reduction, internal fixation. Dental alveolar fractures, this is essentially where not just the teeth get avulsed, but the teeth where they're attached to the bone gets avulsed, and this can involve more than one tooth, and it incorporates either the mandible or the maxilla bone. Once again, this is due to direct trauma. Differential diagnosis is a maxillary fracture, mandibular fracture, pulpal necrosis at the base of the teeth, or LaFour fracture. On examination, you're looking at essentially the displacement of a number of teeth in a row, where the teeth in fact move together on direct manipulation. You're taking a look for associated soft tissue injuries, intraoral lacerations, and once again, looking for that atypical bite or malocclusion. The investigation here you want to take a look at is a CT. Soft tissue may obviously hold the piece in place. So the CT really gives you the best idea in terms of what extent is involved. In terms of management, the viability of teeth obviously depends on the degree of potential trauma, but should be splinted immediately, so try to hold that in place. And then obviously larger and the more unstable the fragment is, the more likely it is to require open reduction, internal fixation. When we talk about facial fractures, we talk about the LaFour fractures. Essentially, there's type 1, which is kind of infranasal, or the infrathird of the nasal passage down to the teeth. LaFour 2 is infraorbital, so in a triangular fashion below the orbits from the nose down to the teeth. And then LaFour 3 is essentially transorbital and down to the teeth. From a sporting perspective, this would be rare in contact sport. However, it can occur. If drop from a height in a contact sport, more likely to be along the lines of like rugby, but more often that you're going to see these in motor sports, potentially cycling and equestrian. The differential diagnosis includes a zygomatic maxillary complex fracture, maxilla orbital and nasal fractures, cerebrovascular injuries, and globe ruptures. The investigation, once again, when we're talking about facial fractures, generally speaking, you're looking at wanting to get a CT scan. You should see a significant amount of swelling on examination. Once again, you want to take a look in that mouth and check the visual acuity and the ocular motor movements, and assess for any kind of associated injuries. Because these are higher mechanisms, once again, this is where you want to think about your ATLS advanced trauma life support, where you're essentially clearing some of the other musculoskeletal areas as you're going through your examination. And for these management, you want to make sure that their airway is stabilized. And once the swelling subsides, generally speaking, that's when your maxillofacial surgeons consider open reduction and internal fixation of these injuries, as they can be quite unstable. So from a fracture overview perspective, when we're talking about head or face, facial fractures require significant deforming force. As a result, you want to consider other injuries like we talked about. Always suspect a cervical spine injury. You want to consider whether or not there is any kind of intracranial injury, and beyond a concussion, whether or not there may be, in fact, the imaginocranial hemorrhage associated with the injury based on the force required to cause the trauma. And also, in terms of from an on-field management, this is one of the things where you want to continually reassess the athlete from time to time, every few minutes while you're waiting for EMS transfer to see if there's any change occurring. SCAT5, Maddox score, COG sport tools, these are all things that you can use to assess for an associated concussion injury, and then examining the soft tissues housed by the fractured bones. So always take a look at the eyes, always take a look at the mouth. That's kind of the basis for your extra examination in facial fractures or suspected facial fractures.